I appreciate the opportunity to come out here and talk to everybody. I'd like to keep this super informal. So if there are questions, just shout them out, but make sure you use the microphone so our virtual audience can hear as well. I'm going to spend the majority of my time talking about some complex patient populations, but I did reserve time at the end just for questions or discussion on less complex things that our colleagues in primary care and general pediatrics may have interest in. So try to balance things out for you. So the objectives of the talk are really to talk about two main complex airway and esophageal conditions: tracheoesophageal fistula plus or minus esophageal atresia and laryngeal clefts, and all the associated complexities of managing this patient population. It's a common condition. These are common conditions. I'm sure every primary care pediatrician in this audience has at least one patient with this based on the epidemiology. And so we really need to partner, with our team with primary care to make sure that these kids are getting everything that they need, which can be easier said than done. We're going to talk about our multidisciplinary approach to this patient population. I'm going to talk big picture about different surgical interventions. Not a great deal of technical detail, but just letting you know there's a lot of options there for us. And then we'll talk a little bit about kind of the long-term needs for this patient population as well, because it's not something that goes away once you have your initial repair. These patients require lifelong medical treatment, and especially when they're younger, quite a bit of follow-up with their pediatrician. So as I said, it's pretty common. I mean, it's from my world, this is a really common thing, something that you see in, less than 1 to 5,000 live births. The initial surgical repair of this condition dates back to the 1940s. And as things have evolved technically for surgery, so has our ability to care for these patients in less invasive ways. The operations used to be big open operations. Now we can do some of them endoscopically through the mouth. The majority of the rest can be done thoracoscopically through the chest. So it's the care of this patient population has turned from like an acute surgical inpatient NICU to more of a long-term chronic condition, which is great for the patients because they end up with an amazing quality of life if they get the right care. There's a lot of comorbidities in this patient population. Anytime I think of TEFEA on a test, I think of Bacterial Association. A lot of these kids have very complex congenital heart disease, even if they don't have Bacterial. And then there's a whole host of GI manifestations from GERD to esophagitis. They can get strictures. A lot of these patients can have feeding disorders, either developmental in nature, anatomic in nature, or iatrogenic. Some of these babies who are in our NICUs for months and months due to complex courses are not being fed by mouth. They get an aversion. That's I'm sure you well know, that's a very challenging thing to address clinically. And then in terms of their airways, in addition to the anatomic things, a lot of these patients have recurrent pneumonias, they have reactive airway, they develop chronic lung disease. And in adults, there's actually oncologic considerations. These patients, even after they graduate care from pediatrics, they need to be followed by an adult GI doc because there are increased risks of esophageal cancer, which is a very, in my adult training, had taken care of. It's a very difficult problem to treat both medically and surgically. So there are a bunch of different, like anything in medicine, nothing's straightforward, right? There's always different ways that things get complicated. So of course, there's multiple different ways embryologically that these tracheoesophageal fistula esophageal atresia patients form. And so the type A, not super common, but we do see it, is just an isolated esophageal atresia with no connection to the trachea. This actually comes in two subsequent flavors. There's a short gap and a long gap. The reason why that's important is a short gap can often be repaired initially primarily by anastomosing the two different ends of the esophagus. Long gap, however, is much more technically challenging Those patients need something usually called a Fulcrum procedure, where basically both ends of the esophagus are put under traction over time and trying to pull together before anastomosis is attempted. I think they're at higher risk for strictures. And it's just, obviously, the more esophagus you have, the easier it is to sew it together. Surgery, I like to joke, is, a lot of basic plumbing. My grandfather was a plumber. And so, if you have two pieces of pipe, if they're closer together, they're easier to put together. If they're farther apart, it's harder. Most of these patients we see have atresia with some type of tracheal connection, the vast majority. The most common being the type C, which is a proximal blind pouch of the esophagus, and a distal tracheoesophageal fistula. But I'll be honest with you, we see all types of these moving forward are in our center and in our program, in our hospital. And like anything surgically, the first repair is the best chance at getting a good repair. And we do see a lot of revisions in patients with either strictures or anastomotic leaks or other complications. And then the other thing that we see in these patients, more towards the airway side, is laryngeal clefts. So laryngeal cleft is basically a defect in the back part of the larynx that increases the likelihood of communication between the esophagus and the airway, which we don't want. It's not good for the lungs. It's not good for nutrition. These things are a little less common, between 1 in 10,000, 1 in 20,000 live births, but they're more common in patients with esophageal atresia or tracheoesophageal fistula, even more common in patients with bacterial association. So our protocol at Children's, and we work very closely and collegially with our general and thoracic surgeons. We look at the airways of these patients every time when they come in and when they're ready to undergo their initial repair by the general and thoracic surgeons to make sure there isn't a laryngeal cleft. We have a very, very standardized approach to doing this. And, it's an important component to their care. There's 4 different types of gradations of laryngeal clefts. This work actually was published by Andy Inglis. Some of you may know the name. He was at Children's for years, retired about 6 years ago. A type 1 laryngeal cleft, super controversial in our field. There's no real good definitions. If you go to Boston, everybody has one. If you go to Seattle, nobody has one, which just means that there's no good definition. But a type 2 cleft, very clear anatomic definition, goes partially, but not all the way through the cricoid cartilage posteriorly. Type 3 cleft goes all the way through the cricoid cartilage, but not into the thoracic inlet. And a type 4 cleft goes past the thoracic inlet. Now, type 3 and type 4 clefts are pretty rare. I've never personally seen a type 4 cleft. Those kids present at birth. They are very sick. Type 3 clefts also tend to present at birth, also very sick, but much less sick than the type 4 clefts. And I have seen and repaired a couple type 3 clefts. The type 2 and type 3 clefts are amenable to endoscopic or transoral repair, which is great for the patients. The type 4 clefts tend to require much more invasive procedures collaboratively between the otolaryngologists and the thoracic surgeons to really repair. And those kids, if one of those kids is born in your hospital, you're going to know it. You want to get that patient to Seattle as soon as possible and intubate them all the way down to the bottom of the carina, as close as you can get to it, to try to make sure you're just ventilating the lungs and not the GI system. Even if you had to selectively intubate right or left side, just to make sure that baby is able to get oxygenation and ventilation, that's really all you need to do to temporize. So here's some pictures of type 2 laryngeal clefts. So I'd just like to point out here a couple of things. So one thing is with actually the virtual patient, people can't see what I use this. Let's see here. So anytime we do this, we do a very standard approach. The patients have an operative laryngoscopy and bronchoscopy. We put these things in here called Lindholm endolaryngeal distending forceps, or laryngeal distenders, just to open it up a little bit so that we can see this interarytenoid region right here. Because if you're going to have a laryngeal cleft, this is where it's going to be. The airway is anterior here, and the esophagus is actually right here. And so we put these in so that you can feel and actually visualize endoscopically this interarytenoid region. And then we swing the hook out and see where the interarytenoid region corresponds to on the laryngeal anatomy usually on the right side. So this one here is a pretty mild type 2 cleft. There is a little bit of a defect that we can palpate here in the cricoid cartilage, and the interarytenoid region is about the level of the true vocal cords. This is more of a true type 2 cleft. You can see here the probe is well below the vocal cords. There's a tiny bit of cricoid intact. But both of these patients had endoscopic repairs and have done very well. I think the key to this is knowing the epidemiology of some of these things and saying, oh, I have a VACTERL kid, they might have a laryngeal cleft. We need to look at them. And in my opinion, and the literature supports this, and our center approaches it this way, a flexible scope at the bedside or in clinic is not able to diagnose a lower grade laryngeal cleft because there's a lot of redundant tissue there. So even if you have a really good scope exam in clinic or at the bedside, you can't tell without actually looking under anesthesia and palpating. All right. So of course, like anything in academic medicine, a bunch of people got together and decided to make some guidelines for the care of these patients. So this is from NASPGHAN, which is the US version of the Gastroenterology and Hepatology Professional Organization. But this was an international work group between the US and our European colleagues. And they did a literature review combined with clinical consensus statement methodology to kind of come up with overall kind of overarching care guidelines and pathways for patients with TEFEA. And this was published in 2016, so not super current, but this is the most recent iteration of these guidelines. And I'm going to pull this up just to show you how complicated this is. This is nothing that I would expect you guys to know. I don't know it. My GI colleagues know it cold. But you can see this. This is right from the NASPGHAN guidelines. And what it shows, this is the care guideline for patients who undergo an initial repair and have no complications. So it's still, there's like 14 steps to this, very complicated. And the question really is, who owns this? And how do you make sure these patients go through these steps? And again, this is the best case scenario here. Healthy kid, repair, no complication. And it's this complicated. This is for patients who have symptoms after they've had their initial surgical repair. And while there's actually fewer steps on this, there's a lot of sub-steps. Like, it's super complicated. And again, how do we fit these guidelines into our care pathways? Who owns what? And how do we ensure that mutual patients are getting the state-of-the-art care, or at least, you know, what is published in terms of what these patients benefit maximally from. And this is really a collaboration between our subspecialists and our pediatricians, community family medicine docs, pediatricians who are really on the front lines of caring for these patients. We see the complications, we do the fun procedures, but you have to step back and globally look at these patients from a developmental perspective and kind of have that overarching trajectory, quality of life perspective for these patients, because that's really important. Because like I said earlier, this used to be an acute surgical thing, and now it's a chronic condition. So at Seattle Children's, and I think this is pretty much the standard at the bigger centers nationally, such as Boston. There's a big center in Florida, Cincinnati Children's, a few others. There's a lot of different specialists involved in the care of these patients. General surgery, otolaryngology, our cardiac surgeons are involved in this with some of the more complex intrathoracic open procedures. Obviously, the GI team is critical to this. Pulmonary with the chronic respiratory conditions. We have a great speech and OT feeding team it's integral, both inpatient and outpatient. Nutrition is probably the most important component to this. Obviously, it's a airway and esophageal thing, but these babies need nutrition in order to reach their maximum developmental potential. And so that's an often understated component of the care of these patients. Obviously, we partner very closely with our neonatology colleagues, our anesthesia colleagues. It's kind of something, I don't know that it would be on your radar screen for, but these kids usually have multiple procedures. They are not straightforward to anesthetize. And so you really have to have a pediatric anesthesiologist who's comfortable with doing airways in this patient population. Anesthesia, sleep medicine, I think that's pretty obvious, especially as the kids get older. We have nursing colleagues that are involved in the care of these patients at every level, from inpatient to care coordination to outpatient. And then we actually have formal non-clinical care coordinators, because you can see how complicated it is to potentially get all these appointments for patients in Seattle. And then our social worker works very closely with care coordination to make sure that families have what they need. And this is a recognized gap, I think, in our care in Seattle as well as nationally. And so the whole point to our center was to try to coordinate this better, take a lot of the burden off the patients and families to try to get all these appointments and navigate our system and have one point of contact, and try to get as many visits in with as many specialists in and testing in with as few visits to Seattle as possible. Because we're seeing patients from Alaska, Hawaii, here, Montana, Idaho, Oregon. We're seeing patients from all over the Northwest and then some. So it's really important for us to consolidate the visits. In terms of diagnostic evaluations for this patient population, there's a lot, too many to list on a slide. We usually start either as an inpatient consult or a clinic visit, referred from either an internal referral or an outside referral. The initial clinic evaluation for TEF-EA is going to include an otolaryngologist, a pulmonologist, a gastroenterologist, a speech and language pathologist, a nutritionist, and a general and thoracic surgeon. We will all be in clinic with them. We will all be seeing the patients, usually in groups of 2 or 3, and then discussing the patients there to make sure that we're all aligned on the care plan. We try to get any imaging or testing done before we see the patients, so that we actually have all the data we need to make treatment recommendations right there when the patients and families are seeing us. Imaging, there's so much imaging that we do. I think a few hallmarks of our imaging are esophagograms. It's a really great test. You can learn a lot by just having a barium swallow and looking at the esophagus. Sometimes we do need to put an NG tube down for that if we're really looking about or concerned about a recurrent fistula, which is, again, not ideal for the patient, but something that we can do easily. We do a lot of chest imaging, a lot of CTA, both to look at the lungs, but also look for aberrant subclavian arteries. We also look for vascular rings, vascular slings. Again, these are just words, but basically intrathoracic differences in the great vessels that can compress either the airway or the esophagus or both, which can make swallowing and getting nutrition much more difficult for these patients. A hallmark of the interdisciplinary evaluation is something called triple endoscopy. I'm sure you've all heard about this, but so what that includes is a pulmonary flexible bronchoscopy. And what they do is first a sleep state endoscopy, because we do monitor all these patients for sleep apnea. So the patient's awake, breathing, but under anesthesia. My pulmonary colleagues will put their scope in through the nose. They'll look at the adenoids, the palate, the tonsils, the voice box, and just make sure, or characterize, I should say, the areas of potential collapse. And then they actually do also look at the lower airways. So part of that, they're looking for fistulas. They're looking for tracheobronchomalacia. They're looking for other anatomic malformations that could impact breathing, feeding, swallowing. And then they usually do a lavage, where they just instill some sterile water and then suck it back out to look at the microbiology and other cellular components in the lower airways. And then In terms of otolaryngology, we then will do a rigid laryngoscopy and bronchoscopy. We'll really assess that intrarytenoid region, looking for a laryngeal cleft. And then with the rigid endoscopy, we get a higher resolution view, but a less dynamic view of the airway. So we also do check that for structural abnormalities as well. And then the GI team almost always does upper endoscopy with biopsies of the duodenum, stomach, and then proximal, mid, and distal esophagus, looking for obviously a myriad of esophageal conditions that could impact the patient's symptoms. In terms of feeding evaluations, we usually start with just a clinical swallow. It's great if you have a feeding therapist that you work with, regardless of their background, OT, speech pathology, or whatever. Start with a clinical feeding evaluation. That's a great tool, and you can really get a lot of information from that. And then if you need to move forward with something a little bit more anatomically resolving, if you will, so something a little bit more that can characterize the issues with the swallow, you get a video fluoroscopic swallow study, or something we're doing more and more is a functional endoscopic evaluation of swallow, or a FEES exam. So during FEES, we'll put a scope in the patient's nose, kind of position it just above the palate, and then our therapy colleagues will give them different consistencies, sometimes different nipples, different flows, different thicknesses of fluid, to try to identify the optimal kind of feeding mechanism for the child. It's a really helpful study. Most younger kids can do this and tolerate for 15 minutes even, but we're trying different things. Once they start to get toddlers, that doesn't work so well. Older kids can also do it. And a hallmark of this is the therapist will actually put some green food coloring, just like regular food coloring from Kroger or QFC or whatever you have. And when the patients swallow, you can actually see any kind of residual green in their airway, and you can even see if they've aspirated it. So it's kind of pretty helpful. And at the same time, you can try different modifications of feeding techniques to optimize feeding during this study. So we also do this in the NICU a lot. Genetic testing, I think we're to the point now, at least in Seattle Children's, where all these patients see genetics. They all get genetic testing. Right or wrong, I'm not sure, but there are so many things that are uncovered, both things that we can intervene on and things that we really don't understand. But that's where it's going. We have a great genetics team, collaborate with them, but it's becoming more and more of an important component to evaluation of these patients. We have pulmonary function testing, we have GI motility testing, and then one of the main things is we do have a complex airway and esophageal conference twice a month, where all the folks who are involved in the care of these patients, not necessarily core members of the team, our intensivists participate very frequently. Outside physicians will ask us to review patients. So we just look at all the imaging, the studies, the endoscopies, and we talk about what the plan of care, what recommendations we may make as a group moving forward with all the different perspectives that we all have from our different specialties, which I think is very powerful. I'm not a cardiologist, I'm not a cardiac surgeon, I don't have that perspective. And so I think that really benefits the patients to get all those folks in the same room thinking about a particular patient. In terms of therapeutic interventions, there are so many. Again, I'm going to talk pretty high level on this. As I already said, nutritional optimization is just so key. These kids need to be followed. If they're not gaining weight, they need to consider NG feeding. There's so many things our nutritionists do to tweak and optimize the caloric intake that it's just so critical. I already mentioned the triple endoscopy. We do offer both open endoscopic repair of the tracheoesophageal fistulas and recurrences. And one of the new things that we're looking at is these patients often, especially the neonates, have severe tracheobronchial malacia. So when they breathe, basically their lower airways just completely collapse, which can lead to pretty significant cyanosis spells and even cardiopulmonary arrest. The traditional treatment for that is to put a trach and a vent on the patient, which is not ideal. lots of issues with both of those. And the patients tend to end up hospitalized for long periods of time. Developmentally, that is not ideal. So we're starting to do some what we call tracheopexies, aortopexies, different thoracic procedures where we try to add some stability to the thoracic airway to prevent or lessen the severity of these Malaysic spells. And one of our general surgeons, Matt Dellinger, is leading the charge on that. There's only a few centers in the country that are offering this, and Matt is working to build that up for our patient population here in the Northwest. Obviously, strictures, anytime you anastomose anything in the body or sew it together, there's always a chance it's going to scar down. It'll always scar down, but how much, I guess, is really the question. Some strictures can be managed either endoscopically or open. Obviously, we try to take the minimally invasive approach when possible. These patients have a lot of pulmonary issues. They have a lot of lower airway reactivity. The pulmonologist really optimize their inhaled steroids, their bronchodilators, et cetera. Swallowing optimization comes with both the characterization of the issues associated with swallowing, and it can range anywhere from just feeding therapy to different levels of thickener. And we do offer a couple different surgical procedures to try to help kids who are slightly older, usually older than 12 months, improve with their aspiration. Eosinophilic esophagitis is a huge component in these patients. A lot of these kids have food allergies, and eosinophilic esophagitis can impact both motility as well as swallowing function. And so that's something that really needs to be managed. Obviously, reflux is an important component, although super controversial in our world right now. As an otolaryngologist, traditionally we give everybody reflux medicines for everything. Lots of PPIs, lots of H2 blockers, and there's a growing body of evidence that in children this isn't good. And the H2 blockers don't really do a ton, and the PPIs have a lot of long-term side effects that we're being very, just becoming aware of. And so from my perspective, I don't manage GERD. We have an awesome GI team. If they feel that it's appropriate after their diagnostic evaluation, which is another reason why the EGD with biopsies is important, is to look at anatomic changes associated with GERD, then they can do that type of management. But the days of us giving everybody PPIs is gone, which is good. And then motility, that's a whole other thing that I'm not really going to delve into, but we do have a motility group. And for select patients, motility evaluations can be very helpful. But our TFEA gastroenterology team is also good at prokinetics and medical management of motility issues as well, even without the invasive testing. Yeah. Pardon me? Can you use the microphone just so the online folks can hear?
What's the basis for why they have more motility issues?
I don't think we have hard science on that, but
And do they have more motility issues?
I think they do, yeah. So part of it is just the anastomosis, right? The esophagus did not develop in continuity. And so that esophageal neuromuscular coordination is disrupted just from that. But then you're in the chest, you're sewing in there, you're disrupting further things. And, you do have scar in there. So I think it's multifactorial. And then another thing that we worry about, and the reason why we get a lot of CT chest, is there other intrathoracic anatomic abnormalities that are also compressing or are causing pressure on the esophagus that makes it even worse too. So there's a lot. The motility, the actual formal GI motility evaluation is like the last stage in all of this. I think there is, yeah. I do not. But it's something that we see. And I'll be honest with you, we, as a non-gastroenterologist, I don't manage that. But up until about 3 years ago, we didn't really have core members of our team from GI. And so we did just double scopes, pulmonary and oto, and we looked at all this stuff. We had some good outcomes, but when we added GI into it, all of a sudden we're diagnosing these kids with way more EOE than we would have anticipated. It's getting managed appropriately, and the outcomes are way better with the GI team, part of our core group. It's night and day different.
Sorry, back to motility. Is it a chronic thing that they're experiencing, like lifelong?
Yep.
And they're on lifelong meds?
Sometimes
Or-
they can be. I mean, that's the thing here is, and what I was, just trying to stress is that this is not an acute like surgical condition now. It's a chronic condition that requires medical management, that it's lifelong. And, as anything in pediatrics, if you do give it time, things tend to get better. But because these patients were born with an abnormal esophagus, they're going to have motility issues for life. At which level and how symptomatic, that's all over the place. But our goal collectively is to improve quality of life, regardless of how severely affected the patients are. All right, so now I thought we'd just talk about a few cases. Again, these are patients that are in your community. I'm sure everyone here has a patient like these patients. They are not unique to big centers because they don't all live in Seattle. They're all over the region. So here's an 8-year-old bacterial patient, complex heart disease, repair, doing great from a cardiac standpoint. Pulmonary artery hypoplasia. Again, there's all kinds of things that are noticed on imaging in this patient population that could contribute to both cardiovascular, pulmonary, swallowing, airway. So it's an important component. Sleep apnea, had a bunch of surgery for that. Still had some moderate sleep apnea, but not terrible. We can talk about sleep later, and sleep studies in kids, but really also struggling with swallowing. 8-year-old still on thickener. Social impact of that is pretty significant, just hard to manage. So we did see this patient in clinic, got some imaging. So we looked chest x-ray here, and not terrible. We got the chest CT, and if I can get this. But what you can see here is a very subtle kind of shelf here, and then kind of some narrowing here. Neither CT nor MRI really image cartilage well. So even our best high resolution fine cut CTs are limited. And that's why endoscopy is so important in these patients, because we can actually see the cartilage. And then we do see some kind of flattening and compression here of the bronchus intermedius. But nothing here is like a slam dunk why this kid had shortness of breath. This kid was very symptomatic, limited their function, impacted their quality of life, and pulmonologists did everything they could do to manage this medically. So we took a look. Here's some images. So here's again a rigid endoscopy, voice box here, no laryngeal cleft. Everything looks great. We're looking at the trachea. This is where we really can see the cartilage. We see these beautiful tracheal rings, a really nice looking posterior tracheal wall, which is the trachealis muscle. It should be vertically oriented. This looks great until we get down here and like, whoops, what's this? We don't see a trachealis. We see cartilage that's 360 degrees around the airway. So this patient has something called complete tracheal rings. And complete tracheal rings don't always need surgery. It depends how symptomatic the patient is. Sometimes they grow with the patient, sometimes they don't. We don't fully understand the pathology. But this patient's complete tracheal rings first weren't diagnosed, which is a reason why we do an airway evaluation upfront when we see these patients as neonates. And the patient was symptomatic. So this patient underwent a big surgical repair, something called a slide tracheoplasty, and did great. And ate. Right. So this is kind of talking, a point that, these patients need to be followed long-term. And that upfront endoscopy and interdisciplinary evaluation would have caught this earlier. And we would have actually had this patient have serial endoscopies every year, in addition to clinic visits every 6 months, just to make sure the symptoms weren't progressing to a point where they needed to consider surgery. So here's another one. pretty common. Toddler with recurrent pneumonias. I mean, this I'm sure is in the vast majority of your practices. Again, TEF, EA, repaired, heart disease, Vactoril, bad tracheobronchial malacia, a genetic mutation that I don't know what means. This is a common thing, a variant of unknown significance. And then again, really swallowing issues. But this patient's hallmark was just pneumonias. They were inpatient all the time. This kid got rhino and they were, in the ICU, which is clinically something to look at in both this population and the patients who don't swallow well. If you have even a healthy toddler who can't take a cold, those patients need a swallow eval because they may be aspirating. So we took a look at this kid. This is a esophagogram. This is one with an NG tube or a pullback. And I think you don't need to be a radiologist to see this right here. So this patient had a recurrence of their TEF. We did get a chest CT, which is, again, not a great imaging study for this. But in this case, you can kind of see here on the sagittal images that there might be a connection there. You might see it right here in the axials too, but pretty hard to see. But on endoscopy, it's pretty obvious. So here is, again, a rigid endoscopy. This is the proximal trachea here. And then this is a rigid bronchoscope that we're now using through the mouth. We're putting a suction through the fistula. And then we have another camera in the esophagus, and you can see the suction coming out. So that's a pretty obvious recurrence there. And clinically, it makes sense, right? The kid is eating by mouth, but just aspirating or had a persistent fistula. This patient had a persistent fistula, underwent re-repair, is doing great. Here's another case, probably resonates with the audience, recalcitrant dysphagia. So toddler just aspirates, horrible dysphagia, can't swallow anything, does okay on thickeners, has had all the medical optimization, is in feeding therapy. Your parents are doing everything, early intervention, you name it, they are doing everything. And the history is really just dysphagia and some atopic dermatitis, which, I mean, how many of your patients have that? We did get a swallow study on this patient. This is a video swallow. We don't actually do video swallows until after clinical swallows, though, because we do want to limit the radiation from the study. So we try to be thoughtful about that. But you can see right here, there's your barium, there's your aspiration. You can see it start here, and it's more prominent here. So definitely aspirating. And this patient had a normal airway evaluation, but this is the EGD. My friend, Dr. Pickens, our GI, one of our main GI docs, did this. And what you can see here is pretty subtle, but you can see some furrowing here. And then you can kind of see these white dots. Same thing, a little more prominent here, and kind of a little bit of dilation too without insufflation or pushing air through the endoscope. This patient was biopsied and actually had eosinophilic esophagitis and went on treatment. Dysphagia improved. So this patient didn't actually have pharyngeal dysphagia. This patient had esophageal dysphagia or some esophageal dysmotility related to the EOE. Patient went on therapy. I think this patient actually just was managed with dietary changes and did really well. And there's, again, I'm not the EOE expert, but it's much more complicated these days than just giving the child some oral budesonide. There's a ton of things that can be done from the GI and nutrition standpoint before going to the steroids and PPIs. And then here's my last case before questions. And this patient, I love this patient, great kid, great family. He had his initial TEF repair, children's, and then I went back to his local community and just didn't follow up with the right specialist for a myriad of reasons. He did have some swallowing issues. He had really bad asthma, though. I mean, that was the hallmark. That's why he came back to see us. Like, his asthma was just not managed. He had seen a local pulmonologist, again, doing everything they could once they got back into the system of care, and just, he couldn't do anything. Like his shortness of breath was so bad, his dyspnea was so bad, he couldn't do sports, he couldn't run around with his friends, really impacting his quality of life. And he's a neurotypical kid, so this was a huge social impact on him. So we took a look. The first thing we found when we did this using our laryngoscopy approach was he did have a mild but present type 2 laryngeal cleft, which was probably impacting his swallowing. And then when we interrogated his TEF, so this is the distal trachea here, the main stem bronchi are here, and here's the pouch that's left when the TEF repair is done. So pretty standard looking, but when we interrogated this and when we looked from the esophageal side, which is here and here, he had a recurrence. And so it was a small recurrence, but he was still having GI contents into his lungs. And that was likely, well, it was the cause of the majority of his pulmonary symptoms. So this patient underwent a complex re-repair with a pexy operation initially. We got him through that, and then we did an endoscopic repair of his type 2 laryngeal cleft about 3 months later, and he's doing great. And the main thing for him, he's still got a tiny bit of dysphagia. He's on just slightly thickened liquids on what we call level 2 or half nectar. There's all kinds of different terminology that's evolving for that. But his asthma symptoms are gone. He is back, able to play soccer and do all the things with his friends that he wants to do, which is really our goal, right? It's not to do cool surgeries and take cool pictures. It's really to get these kids back to a point where they're functioning at the highest level that they can. So just to conclude, this is a complex patient population, but it's common and it's in every community. This is a chronic condition that needs to be managed over the patient's life. For a lot of the issues, it does require coordinated interdisciplinary care, but there's also a huge role for collaboration with the primary care team. But the outcomes are great, and these patients, our unified goal is to maximize their quality of life. So with that, here is our referral information. We're always available if you have a patient you want to discuss to. I'm happy to talk to community docs or APPs by phone or email, whatever works for you. And then B is our program coordinator who can get anyone in touch with us. She's awesome. She's worked with us for a long time in other roles and is very passionate about this patient population. And now with that, I'd just like to conclude and answer any questions either from the chat or from the audience here. Thank you.
Hi, where I'm from, Yakima Gastro. I'm Rosa Maria Blackstone. I'm a APP. Handoff, once they turn 18 and they're no longer part of children's. I have a young man who's about 24 who has a little bit of a history like this, but now I'm managing his GI, and I'm concerned because he's a little bit more complex. So how do you arrange the handoff?
We do have a team at Children's that works. It's probably best if they hand the patients off to someone at the UW, which obviously doesn't work for somebody who lives here. And I think that's a gap, honestly, not just for this patient population, but for many of our pediatric patients who are involved in various centers, our craniofacial patients, our some of our cancer patients, although I would say that they're much further ahead with the handoffs than we are. Some of our trach patients, our chronically trach invented patients too. We don't have a great system for that. I wish I had a better answer for you, but it's really tough. Just given the structure of everything in American healthcare to ensure that. The one thing I would say, if you have a patient that's followed through our program, we're happy to talk to you. We're happy to facilitate any conversations you want to have with the care team. We're happy to facilitate getting the records you may need to appropriately care for that patient. And we're also happy to field questions if you're like, oh, this isn't going right. I just want to talk to somebody who's known this patient their whole life. Yeah, we're there for you. Absolutely. That's, I think, what we can say.
I would like to state that I am greatly impressed with the multidisciplinary approach to these problems that's being able to be handled very, very nicely at Children's for the whole regional area. Thank you. Thank you.
No, we appreciate that. And I think, I've been at various places throughout the country for training or, as an attending physician. And one of the hallmarks of our team at Children's is we don't compete with each other. I don't compete with the general surgeons. We're a team. Like we did 10 triple endoscopies in complex patients on Thursday. 4 different my general surgery colleagues came into the room, and we were texting them and calling them and having them look. I mean, these are our patients collectively. And so that, I think, is a real strength. To your point, it's interdisciplinary, but there is no kind of competition between us to do different things. And it's really the best thing for the patient. So thank you.
Tammy Shelley from Grandview. This is just a thing for me to learn. I always thought of tracheoesophageal fistulas and esophageal problems as like embryologic and something that happened while they were inside. So how do recurrent fistulas work? Is that something that got missed the first time around, or is it something that just starts reforming because somehow this kid likes fistulas?
Yeah. So embryologically, this is very complex, and it is an embryologic issue. And we have some great basic scientists that I collaborate with that we're working on looking at kind of this trachea and esophageal development. But, depending on when you went to med school, it hasn't changed what you learn in med school. And we really don't know that much more about the molecular genetics and cellular biology of this particular point of development. But anytime you do a surgery, there's always a chance of getting a fistula. If you leave a tiny little bit of mucosa, that can always recannulate. If there's any kind of inflammation or trauma or, anything can just slightly open that up. The body's inclination is to continue that opening. And that's why these patients need to be followed long-term. They can have the best repair by the greatest surgeon ever and still have a fistula through no technical fault. Now, there are some technical issues that can come up, but those are things we work to identify early and address. But it's really not often a technical failure. It's just kind of bad healing. Any other questions in the chat? Any questions about, we have a couple minutes, just general pediatric otolaryngology, sleep, ear infections, anything that, when to get a sleep study, just anything off the top of your head, just.
This is about sleep and tonsils. And it seems like a few years ago, we would refer patients who had snoring and apnea to the otorhinolaryngologist, and they would take their tonsils out. And now I'm seeing pushback to people wanting to get sleep studies before they do that. Can you tell us what your position is on that?
Yeah, so it's not my position. There's actually national guidelines that are evidence-based, established by the American Academy of Otolaryngology, head and neck surgery. One of my partners, Sanjay Parikh, was actually on the group that did it. And all these guidelines, for at least for ear tubes, tonsils, and all that, are on the Academy website, and they're free to download, which are great resources for primary care. But the criteria for getting a sleep study are, if the tonsil size doesn't correlate with the symptoms. So if you have a kid that's really symptomatic but has small tonsils, now the evidence doesn't support that at all. The evidence actually shows that our ability to predict sleep symptoms and sleep apnea based on physical exam is terrible. But that's what the guidelines say, and that's a whole nother talk that I'd be happy to give later. But if tonsil size does not correlate with level of symptoms, in kids with certain medical complexities, so kids with trisomy 21 probably should have a baseline sleep study. They should have it before age 3 anyway. Kids with craniofacial differences, so that may be something you're seeing through our craniofacial center. I see lots of patients. I'm part of that team as well, all those kids per the guidelines should have a sleep study. Kids with mucopolysaccharidoses. So it kind of lumps them into the medically complex kids should probably have a sleep study before considering surgery. But otherwise, healthy kids, if they have snoring, pausing, gasping, daytime symptoms, ADHD, behavioral issues, things like that, then they would be a candidate just to go directly to surgical treatment. Yep. And that's pretty standard in our practice.
Laryngomalacia,
Yeah.
curious about it.
Super common. It's a term that I think is really misused. So laryngomalacia is when you have some collapse of the supraglottis, so the top part of the voice box, that impacts breathing, causes stridor. But what it really does is it impacts the suck, swallow, breathe mechanism that babies need to feed. Personally, not evidence-based. I think all babies have some level of laryngomalacia. When we start to worry about laryngomalacia is when the babies can't maintain their nutritional status. So if they're starting to fall off their growth curve or they can't get on a growth curve, those are babies that we need to see pretty urgently, because once they get to the failure to thrive part, that's something that takes them a really, at least in my experience, a really long time to come out of. So we want to get them not there. So those are the babies that need surgical intervention, which is a supraglottoplasty, just trimming those tissues. Only about 10% of babies, based on the literature, who have quote unquote laryngomalacia need a surgical intervention, but it's really the feeding and the growing part is really the most critical to that. The stridor can be terrifying to parents. Makes sense, especially first-time parents or parents who have other children, but none of the other children had this level of laryngomalacia. And so we need to see them, reassure them. We'll often scope them in clinic, but it's really the growth trajectory. And it's really hard. I mean, I've been on a run-in clinic where I've actually admitted 4 kids in the past 6 months who come in for laryngomalacia. And I look at their growth curve and they're like, Z-score is like -2.5, and they're in the first percentile of weight for age. Those kids need to be admitted. They need a feeding evaluation. They need an NG tube. They need nutrition, and often they need surgery. But we can't do surgery right away because nutritionally they need more before we can really do that for their recovery. So it's something we take seriously, but it's a term that's thrown around, and I approach it as there's kind of anatomic laryngomalacia where you can have the floppiness of the voice box. Every baby has that. But the condition of laryngomalacia is when the anatomic part impacts feeding and growth and development. And there's no grading scales that we use that are evidence-based for laryngomalacia. So mild, moderate, severe doesn't mean anything. So it's really growth and development.
He brought up the issue of tonsils, and I would like to state a rather interesting, frustrating situation. Beta strep is the trigger agent for psoriasis. Psoriasis is an autosomal dominant condition, and these people are very, very susceptible to beta strep infections. And yet beta strep requires a host, and people tend to be the host for the strep. If a patient who consistently has psoriasis, throat swab consistently shows beta strep, treated with antibiotics multiple times, constantly is positive for beta strep. Question then, is a tonsillectomy indicated?
That is a great, because there's no evidence on that. I think that is so first of all, tonsillectomy is not a benign procedure. Kids die from tonsillectomy in this country every year. So that's an opportunity for shared decision-making with the patient's family. I think it could be certainly considered. Depends how the psoriasis is impacting them, how the repeated antibiotic exposure is impacting them. So I do think it's an option. It's not in the guidelines because there's no evidence, there's not bigger levels of evidence on it, but I think it's something that could be considered for sure. Just requires a discussion with the family. Yep. I mean, the two main indications are OSA or sleep disordered breathing, which is OSA without a sleep study. That's like 90% of the tonsillectomies we do. The other 10% are for other things like the periodic fever syndromes. There's not a ton of evidence on that, but we still do it. And to meet the true criteria for chronic tonsillitis or recurrent tonsillitis, you need to have 7 infections in 1 year, all documented with a complication such as adenitis or what is it? It's 7 and 1, 5 and 2, or 3 and 3. I mean, the Paradise criteria, and these are from the 80s or earlier. I mean, we just don't do a ton of chronic tonsillitis TNAs anymore because the criteria are so hard to meet. But with the psoriasis thing, I think that's just a conversation. Yep, the family wants to do it. I think we would offer it. We're seeing more and more with both the tonsillitis patients and the ear infection patients, parents coming in and saying, I don't want any more antibiotics. No more systemic antibiotics. We don't want that. And the guidelines haven't caught up to it, but I think it's something that we recognize and respect. I personally wouldn't want my daughter on tons of Augmentin. Any other questions? All right, well, thank you so much.